All right, welcome everybody. Thanks for coming to this lunchtime symposium on day 2 of TCT. Hope everybody's excited and still fresh. It's great to see people in the audience at renal denervation again. Oftentimes we felt that we were just talking to ourselves, and there's a lot of hope on the horizon for this technology, certainly in the next few weeks we anticipate. So the title of the symposium is The Next Wave of Hypertension Management, Ultrasound Renal Denervation Technology and Clinical Evidence. And we're going to have a pretty practical-based symposium where I think it'll be approachable in terms of what this could be like and what we can expect. I have a fantastic panel and co-moderator here. Naomi Fisher is here, Michelle Azizi, Philip Lurs, and Jay Geary. Different specialties, different areas of expertise, but one thing that's common and uniting all of us is that we've all worked in this field for quite some time, so we're excited. Here is our faculty again, some of us looking younger than we currently look. So as far as the agenda, I'll do this brief intro. We'll talk about what is ultrasound renal denervation. We'll talk about highlights from the Radiance program, which Michelle will show you is among the highest level of evidence for a device-based technology that you'll see. We'll hear about prior studies that have longer-term follow-up data from Philip, because he's fortunate that he's had this available for him for quite some time. And then we'll transition to what this is going to be like in clinical practice, hypertension care, and this is really germane to the what we think is going to be an imminent approval of this technology. Naomi will finish because I have to run to a different meeting. So as far as what the milestones have been, back in 2009, 2011, there was development of these technologies. In fact, in the 1950s, there was surgical evidence that you could do denervation surgically, but unfortunately that was a pretty morbid procedure, and so catheter-based strategies started coming up around this time. And essentially in the 2012 to 15 range, there was CE mark approval. But as you know, Simplicity HTN-3 came out at that time, essentially quashing all interest in the field. And one of the few companies that persevered besides Medtronic was Recor. And so at that time, studies were designed, and Michelle is a person who's a scientific mind, but yet wants to understand how to apply things in clinical practice. And in order to do that, you have to study it in the right way. And so studies like Radiance HTN Solo, this off-med design, taking patients off medicines and then isolating the effect of denervation versus sham, it was entirely Michelle's conception, along with Laura Mori as well. They let me along for the ride around that time, and Radiance Trio was done. These were patients you couldn't take off medicines. These were patients that required medicines because their blood pressure would go too high otherwise. But Michelle devised a plan to basically stabilize the regimens across arms so as to isolate, once again, the effect of denervation versus sham. And of course, it met its primary endpoint. And then finally, just this past year, the Radiance 2 trial, which was the FDA approval trial, met its primary endpoint. We submitted it to the FDA, and we had a positive panel response. So overall, it's been a great journey. It's been great with friends. It's always better to be on a journey with friends, not just by yourself. And now we're here at this point where we think there's imminent approval. So with that, I'm going to hand it over to Dr. Geary, who's going to tell us a little bit about what renal denervation is.
Perfect. That worked out. Okay. Thanks everybody for the opportunity. This will be quick, but I think instructive into how ultrasound renal denervation works. As Ajay alluded to, the idea behind renal denervation is very long-standing. As he mentioned, it goes back to the middle of last century where surgeons were doing this, but with high rates of complications, although they did see efficacy in dropping blood pressure. And what was learned, even at that time, and is tried to be focused on now, is some of the anatomical issues related to how to perform good denervation. And part of that is understanding how the renal nerves run, and that's here in the third frame here, where you're looking at the periadventitial tissue, where you have renal afferent and efferent nerves running there. And what you're ideally trying to do is disrupt those nerves, in this case with ultrasound-based technology. So you can imagine that some key aspects are necessary here. In an ideal world, you would be able to deliver the ultrasound to the appropriate depth to actually target those nerves, but not damage tissue in between. And then secondly, you ideally would have circumferential ablation. So you've got nerves being denervated all around the circumference of the renal artery. If you don't accomplish all that, you might end up with incomplete denervation and perhaps not as good of a procedural result. And we have a feeling that in some initial negative studies of renal denervation in a different era, over 10 years ago, maybe incomplete denervation may have been one of the etiologies for why we didn't see what we wanted to see. So as I mentioned here, the Paradise system that Recor's developed aims to do all of this in this way, where a balloon is blown up. It causes apposition inside the renal artery. You will initially size the renal artery and choose a balloon that's appropriately sized for that vessel. And there are 6 different balloon sizes right now. You'll size it. You'll make sure your balloon is inflated, and we'll show you what that looks like in real time. And then you press a button, and then it's dummy-proof. The machine will do the rest at delivering the appropriate frequency of ultrasound to target those renal nerves. The other important thing is that naturally when you're delivering ultrasound in a focused fashion that's supposed to ideally ablate, you do worry that you're generating some heat, and can that be damaging to the arterial wall and even the intima that you're up against? You could get thermal injury to the wall. Well, specific technology exists here to create continuous cooling, and that's with sending water basically through the balloon to keep things cool, but still allow the energy to be delivered to where it needs to go. This is a frame of kind of how it looks, when the ultrasound is on. And you can see that you actually have, the thing they notice here is you have circumferential denervation here. So let's just go over what the steps are to actually do a case, because that's what many of you will probably be doing in the near future. So right now, the device is going through a transfemoral access, and you'll go ahead and place 7 French sheath through there and put a 7 French guiding catheter into the renal arteries after taking this first non-selective aortogram to identify where they're coming off. Here you want to look for a few different things. You want to make sure that you haven't missed any atherosclerotic renal artery stenosis, there's no FMD, etc. And then once you've confirmed that, you'll go ahead and engage the vessel. With this, on these shots or on selective angiograms, you can use quantitative vascular angiography to measure your vessels, or you can place an IVUS catheter in and get a very specific measurement. I do like my angiograms to include portions of parenchyma, both pre and post, just to understand how things looked and if you're monitoring for complications. So you'll notice that we often do that. This is just an example of how an IVUS looks. Many of you know how that looks if you really want to get what the appropriate sizing is. Here you see selective engagement with a catheter, and that catheter can be a renal-specific catheter or a JR or an IM catheter. They all have reasonable shapes usually to engage the renals. It can be a short-length one if you're coming from the femorals, usually a 55 or 65 centimeter guide. You're in there, and then you're just going to place your workhorse wire in there. So whatever your choice is, ProWater, BMW Universal, Trumo, Run-Through, you name it. I'm sure you all have your preferences out there. But a nice, safe wire. And that's going out now into the parenchyma, and this is not a hydrophilic wire. It's not something that's going to cause a lot of damage. And then you're just going to go ahead and take your denervation catheter now over that has the balloon on it. Once that balloon is in place, you'll press a button, and then that will inflate, but it won't necessarily deliver the energy, and you'll make sure you're opposed. How do you make sure you're opposed? You take a little puff, and that's what you see there. You see how the stagnant column of contrast is held up? It's because the balloon's up and not letting that contrast go past it into the rest of the vessel. So you're going to take that puff. That verifies that you actually have apposition, which is very important. And then you press the button one more time, and then the renal denervation is delivered. In each vessel, you'll usually do that 2 to 3 times, separating by about 5 millimeters as you walk your way back to as close as 5 millimeters from the os. And there are some times where you'll see just very slight changes in how the vessel looks. It was smoother in the first case, and you can see slight irregularities here that are indicative of either a little vasogenic edema or spasm. This is something that is noted in virtually all cases to go away on its own. So there's nothing to worry about here. This does not represent a dissection or any other trauma that is really important. It is important if you learn how to do these cases that you're going to be able to recognize some of those much rarer complications though.
Thanks so much for that, Jay. That's a great basic, depiction of what the procedure is like. We were involved in a document that Sky recently put out in terms of operator requirements and training and that kind of thing. And I know there was some passionate argument on this. So tell us a little bit about what your thoughts are in terms of what's required. Can anybody do it? What do you need to learn?
Yeah, I mean, we're largely in a room of interventional cardiologists. I'll tailor the comments to that if it's okay. And I do firmly believe that the skill sets that we have in performing PCI are easily translatable to performing renal denervation. There are some nuances that are really largely cognitive to understand. When you want to understand what the renal artery anatomy looks like. You want to use your best practices for access right now at the point where it's transfemoral, although certainly we can envision a future time where perhaps it will be going through radial access. And then you want to understand complication management. And the two complications that you worry about, I think, are distal wire perforation and parenchyma, and dissection, theoretically, in the renal arteries, although it's vanishingly low, but it could certainly happen more as this ramps up. But bear in mind, those are complications that we deal with, and we would deal with in fairly similar fashion in a lot of coronary intervention. So I personally don't see massive obstacles to dissemination of this technology to a broad array of operators who do a reasonable amount of PCI. That's my opinion, and I'm curious if others agree.
No, I completely agree. I think one of the challenges can be just actually engaging the renal arteries, and certainly if you think of a more atherosclerotic disease population, that's when it really becomes most manifest. But for the types of patients that were typically enrolled in these studies and we think would largely be, getting this therapy, I think in general it's pretty straightforward. Sometimes pre-procedure imaging, if you have it, is useful to identify if there are accessory branches, because recall, if you leave a large accessory alone, you're not going to get as completed denervation results. So these are cases that you'd want to treat those as well, treat as much as you can in that way. Michelle, comments?
Just one comment. You already said it. Just be aware about fibromuscular dysplasia, which is found in 4% of the cases, specifically in women and in hypertensive patients. So, and this is a contraindication of doing renal denervation. So don't try or making an angioplasty and secondarily going there, making a renal denervation. It would be worse. I just have one comment on what you have said. I'm perfectly sure that interventional cardiologists can do this. The only thing that we have written in the European consensus is that in the cath lab you have that you need the presence of large enough stents, because the renal arteries are larger than coronary arteries. So you should have this somewhere and not to look for them at the time of a problem. So this was my only comment.
No, thank you for that comment. And basically what we're referring to is proper dissection management, where when it's a dissection, you're usually going to manage it with a balloon expandable stent, but you're going to want stents that are in that 4 to 7 millimeter range to properly manage that for the most part. It would be vanishingly rare to have a perforation in the main renal artery. So having covered stents, I think, is unlikely to be needed. But other techniques of managing distal wire embolization, I think, are things that you do need to be aware of.
And I mean, just to point out, in the studies, these events were not seen. So, and these were with largely operators, especially given the fact that renal stenting has fallen away from most people that didn't have a lot of experience in the renal arteries. So it's fair to say that these are very safe procedures, but you always want to be prepared for any outcome. I think the final point I would make before we get to Philip is that, one of the exciting things about this area specifically is that, after a certain period of time when you are used to doing what you're doing, it somewhat gets rote. It gets perhaps even a little bit boring. And with any new therapy, or some new therapies, it's a completely you have to open your eyes to know about what FMD is. You have to know about combination antihypertensive therapy. And for some people that's daunting, and so that's okay. But for others, it's exciting because you learn new things. You meet new people. I never would have met Naomi if it weren't for this, and I've learned a ton from her. So it's an exciting time for the field, I think, for a lot of us. Philip, go ahead.
Maybe one thing to add, you should also have some pain medication in your cath lab. We shouldn't forget about that. There's all sorts of different protocols to do that. I guess we're still learning. Best you do what you're most comfortable with, but it can be a little bit painful, but with the right medication, it's not a major problem.
Yeah, currently, I'll tell you, in at least my experience, stereotypically, it's a 7-second inflation that you're delivering the energy, and at second 5, almost uniformly is when patients have pain. So they have it for 2 seconds. They're usually getting about 6 total inflations, so you can expect that. But it can be painful, as was mentioned. So we use relatively significant moderate sedation.
Yeah, I mean, in the trials in U.S. practice, there was almost no GA, and it was all done conscious sedation in the lab. Interestingly, in Europe, there were a fair number of GA cases, but correct me if I'm wrong, Philip, but there are a lot of places in Europe that actually don't give fentanyl and Versed for routine diagnostic procedures or even some PCIs, which I think the US population, they're a little more uppity, so you have to do it. But I think that it also really helps that the ablation is that 7 seconds. Maybe New Yorkers are more uppity, so we typically see the toes move a little bit at 3 or 4 seconds, but you can very easily then tell the patient it's going to be only 3, 2, 1, and it's done, as opposed to other technologies that I've been involved in HTN3, for instance, where it was literally like a 2-minute trying to keep contact with the wall, the patient's breathing, and all kinds of stuff going on. So I personally think this is a pretty marked advantage of this type of technology, but you do have to remember you're doing a few sonications, so you have to be prepared in advance.
And it's a procedure where GA is definitely not needed. I mean, there's no need for that at all.
No need for what? For which? GA. Oh yeah, absolutely. All right, Michelle, you want to tell us a little bit about the data and the program that, honestly, you led. You're the father of this program in a sense.
Thank you. As you said before, it's really a teamwork, and altogether we brought all this information and this data. So these are my conflict of interest. So just to remind you and to repeat what has already been said by Ajay, these are the different trials we have been conducting during these years, and those off medication, solo and Radiance 2, and on medication with the TRIO trial. As you see here, we restricted age to between 18 and 75. Why we restricted to 75 years old is because the early trials included more people who were older, and in fact, when you're older, you have more stiffness, aortic stiffness, and the probability to have a drop in blood pressure, whatever you do, giving drugs or making an intervention, will be smaller. So it was to increase the potency, the possibility to show a blood pressure lowering effect. This is why it was restricted to 75 years old. Then the blood pressure levels are classical, at least all over Europe. I know that you have changed here in the US the threshold for hypertension, but these are the threshold we selected at that time when we designed the trial, which was the classical threshold of 140 over 90 millimeters of mercury. And as you see here, either in solo and Radiance 2, they were mild to moderate, 0 to 2 antihypertensive medication. So this allows you to stop medication for a period of 3 months, because this has been shown in drug trials that when you stop medication in this type of patient, among thousands of patients, there have been meta-analyses showing that this stopping period, you don't have any event, cardiovascular event, or etc., because these are patients with mild to moderate hypertension of middle age. So this is the reason of this selection, and to prove the concept of renal denervation, we should stop the medication because this is a major confounding factor when we are on medication and patients are changing medication. So we did antihypertensive washout for these 2 trials. Then if we look to the TRIO trials, which was initially, the renal denervation was developed for patients with resistant hypertension. And there was no reason that there is not a continuum of blood pressure lowering effect, whatever the population we're selecting, mild to moderate or very severe hypertensive patients with resistant hypertension. The problem there was the confounding effect of medication. So to demonstrate also in this population that renal denervation lowers blood pressure, we standardized completely also the treatment and to give a triple pill therapy in a single pill combination. So we also entered patients with this level of blood pressure, having more than 3 antihypertensive drugs, and we switched them to a 3-pill combination. So what we learned there is that around 40% of the patient, even having 4, 5, 6, 7 antihypertensive medication, when you switch them to a single pill combination therapy, had their blood pressure normalized. This was really a major effect of this triple combination therapy because they are taking it. Remember that our main problem in hypertension is non-adherence to treatment. And you have the more you prescribe antihypertensive medication, the less patients are taking the medications. So here we recruited all those who finally took this pill. And then on the basis of what we learned was not to use office blood pressure, but ABPM to demonstrate the efficacy of the blood pressure lowering effect of renal denervation. So we took ABPM as a criteria of entry, and we had to demonstrate that after 4 weeks of running, either washout of 0 to 2 antihypertensive medication or maintenance of a triple therapy in a single pill, patients remain hypertensive by verifying the ABPM, which is here. As you see here, we did a CTA or MRI to check the renal artery anatomy, and we found 20% of the patients who did not have a fully eligible renal artery anatomy, either fibromuscular dysplasia or atheroma, ostial atheroma, or really complex renal artery anatomy. So in total, we randomized, you see here, 293 patients with ultrasound renal denervation against 212 patients in a sham, for a sham procedure. This was done at cath lab, the randomization, and the follow-up of the patient was made by physicians who were maintained blinded to the treatment assignment. And the primary endpoint of all these trials was at 2 months, and this was the analysis of the changes in daytime ambulatory systolic blood pressure. No medication changes were allowed, unless there was a blood pressure level which was threshold, which was 170 over 105 millimeters of mercury home blood pressure, which was exceeded. So these are the patient characteristics in the 3 trials. You see that we had majority males, specifically in patients with resistant hypertension. Mean age was similar in all these trials, with a low proportion of patients above 65 years old. White people was the majority of this patient. Black or African American, you see, are between 20% and 14%. And their BMI, they were overweight, and those with resistant hypertension were more obese patients. You see here the gradient in BMI. These are the blood pressure lowering effects that were observed at 2 months in each of these trials. What is interesting, either you take those of solo off-med study, Radiance off-med study, and Trio on-med, you see the baseline daytime ambulatory systolic blood pressure was similar, either off medication here or on medication. And the drop in blood pressure, as you can see with renal denervation here, was extremely similar, between 8 and 8.5 millimeter mercury decrease in daytime ambulatory systolic blood pressure, whereas in the sham group, you had really almost no change in blood pressure or slight change in blood pressure due to the addition of antihypertensive medication during the 2 months follow-up because of patients having a higher blood pressure level. So the difference between groups is also extremely similar in all these trials. So this consistency is very important. Different patient population studied at different times, and we find exactly the similar difference between the 2 groups. So this also increases the confidence in the results. So because all these trials were designed similarly, so we did did this analysis, a pooled analysis of all this data. This is individual patient pooled analysis. And you see the consistency of the blood pressure response. What are the way we measure blood pressure? The daytime ambulatory systolic blood pressure, nighttime blood pressure drop, home systolic blood pressure drop, and office systolic blood pressure drop, with very homogeneous differences here between groups. It's important to notice here the drop in blood pressure during nighttime. This means that when you do a single procedure 2 months before and you look at the overall ambulatory blood pressure profile, you have a similar drop during daytime and nighttime. Nighttime blood pressure is highly associated with prognosis, cardiovascular prognosis. So it's a good thing to have a lower blood pressure during nighttime. So it's what we are saying, an always-on effect during daytime and nighttime. To achieve similar things, we need a very long-acting medication if we want to compare, or twice daily administration of a short-acting drug to have also a lower blood pressure during nighttime. And these differences and this drop in blood pressure are highly clinically pertinent. And so with just 5 millimeters of mercury drop in blood pressure, systolic blood pressure, you have already a major impact on prevention of stroke, cardiovascular diseases, etc. So this is very important. This is not nothing as a drop in blood pressure. Another argument here comes from patients who crossed over, who were initially in the sham group, and then they crossed over after 1 year. And you see here with this much smaller number of patients with similar number of antihypertensive drugs and a similar dosage of this medication, you see the drop in blood pressure. You have, this is daytime ambulatory systolic and diastolic blood pressure, and you have a 10 millimeter of mercury drop in blood pressure, which remains after 6 months present without any change in antihypertensive medication. So if you want to know more, you will have a 327 presentation given by Michael Block at Abstract Station 3 about the pooled crossover data, which will be presented today. On the long run, these are the efficacy data we have observed until 30 months for Radiance Solo and 24 months for Radiance Trio. We have had some patients who crossed over, so we only look at those who remain in the renal denervation group, and you see that the blood pressure lowering effect is maintained during this whole duration. And as written on the right side of the slide, here you see that the 10 millimeter of mercury drop in office systolic blood pressure leads from meta-analysis on drug trials to 20% reduction of cardiovascular events. So the 36 months data of TRIO will be presented at the next AHA meeting. If you attend there, you will have also this new result presented. In terms of complication and major adverse events, these are the pooled data which have been already published. We had one death, which was a sudden death occurring more than 3 weeks after the renal denervation procedure, which was not related to renal denervation procedure. It was in a TRIO trial with a high-risk patient who had had prior myocardial infarction. We have absolutely no problem in terms of kidney dysfunction or embolic or dissection or whatever. We had just access site complications and one patient who had hypertensive crisis and another who had one major cardiovascular event. But these are patients who were in the TRIO trial, which are as much higher risk than the other. Just to remind you, in Simplicity HTN3, the rate of occurrence of cardiovascular events in patients with resistant hypertension was around 15%. So this is a very high-risk population when you're dealing with patients with resistant hypertension. And to finish here, we did not observe any renal artery stenosis greater than 70% at 6 months using CTA, so we are sure that there is nothing which happens. This is not mine. I don't know what is this light here. So I will stop here. And thank you for your attention.
So, Michel, thank you for everything you've done, really, to bring the field to where it is now. We learned a lot from the early generation studies. I think the question that many listeners may have is, so what with a blood pressure delta of 6? So what with a blood pressure fall of 8? Can you help explain the importance, first of all, why you choose ambulatory blood pressure as your outcome and not office?
So, again, when we designed the trial, we were at the stage where Simplicity HTN3 had failed to demonstrate efficacy using office blood pressure measurement in terms of primary endpoint. And the way to demonstrate efficacy in the hypertension field, the best way is to use ABPM to get rid of all the problems due to office blood pressure measurement. But this is the complexity of a trial. This is not the real life. We did it extremely complicated by having ambulatory blood pressure measurement, home blood pressure measurement, monthly home blood pressure measurement, office blood pressure, all types of different blood pressure measurements to be sure that we are going to see the effect of renal denervation. So we were at a very early stage, so we wanted to be sure what we wanted to demonstrate. So this is first part of my question. Then people are mixing the results in terms of the delta we are observing. And people don't, everybody is thinking is 6 millimeter mercury of office blood pressure. No, it's 6 millimeter of mercury difference in daytime systolic ambulatory blood pressure, which is large. It corresponds to 10 to 12 millimeter of mercury. This has been always observed in drug trials. The response, the blood pressure response by ABPM is around 70 to 60% what is measurable by office blood pressure. So we are, everything we observe is what is expected when, in terms of blood pressure lowering, and these effects are associated from meta-analysis with a clinical benefit. So this is, I'm sure this is a true clinically pertinent drop in blood pressure.
I am as well. We have to recalibrate our thinking because for decades, for a century, all trials have been based on changes in office blood pressure. Home blood pressures, out-of-office blood pressures are much more representative.
Do you mind if I just ask a follow-up question to either one, Naomi or Michelle? So we're talking about the average is what I saw here in the JAMA Cardiology paper that you all published. Let's call it 10/5 or 8/4, whatever you want to say. But is that what you're actually seeing in an individual patient? What we will see in an individual patient, do we see consistently 10/5? Or do we see a spread where some have a lot more, some have a lot less? What do you think?
Again, a clinical trial is very artificial. When you're going to see a patient, you're not telling him, okay, you may be randomized to sham or to an denervation. He will have, or she will have, truly the denervation. So the effect that you're going to measure in real life will be the addition of a placebo effect or sham effect plus the effect of the denervation procedure. It will be always larger. This is what we observe with medication. This is when we give a medication to a patient, in reality, is we have the placebo effect, because we have given him whatever pill, red, blue, and it changes depending on the color of the pill, plus the real true effects. But I don't care. As I already said, any millimeter of mercury drop is very important because this is associated with the prognosis. So, but you're right. There are patients who absolutely do not respond to renal denervation, but there are also the same proportion of patients who do not respond to antihypertensive medications. You have a JAMA paper just published where monotherapy were compared to each other, and you have this spread of response also with each of calcium channel blocker, diuretics, ACE inhibitor, etc. Everybody is forgetting that, well, in real life when we are treating patients, well, we have some patients, if they take the pill, first thing they have to take the pill. So unfortunately, the majority of them do not take them. So if they take the pill, still some patients will not have any response to the blood pressure lowering effect of these drugs, of one single drug.
Great, we'll take a question from sure.
Yeah, Dr. Fisher just asked a question, why you use 24-hour, actually it's now 24-hour AMBP, ambulatory blood pressure monitoring. It's not only ambulatory blood pressure monitoring, it's a daytime.
Yes.
And why you use a daytime, not 24 hours? And now question number one. Question number two, why you use follow-up them only for 2 months, not 6 months? So there will be a lot of followers after this trial. So what are your suggestions? 6 months or 2 months, 24-hour or daytime?
So my answer concerning ambulatory blood pressure, the question is, what is the primary endpoint? When you measure daytime and nighttime ambulatory blood pressure, you're measuring 24-hour ambulatory blood pressure. We selected inside this ambulatory blood pressure measurement the daytime parameter because from my experience coming from other trials, previous trials in drug trials, it was if you use 24-hour blood pressure monitoring as a primary endpoint, you may end it up that some patients do not have nighttime blood pressure, and so you drop the ABPM because it's not valid. So to be sure to have the correct number of ABPM measurement and patients do not stop the ABPM measurement, this was my experience. And all my trials have always been done with daytime ambulatory blood pressure. And to be also to reproduce always the results. This is consistency from one trial to another to find always a similar sham effect or placebo effect, etc. Gives you a consistency of what you are doing. This is the rationale for using daytime ABPM as a primary endpoint. But we measure 24-hour ABPM, and we also show the difference in terms of 24-hour ABPM and nighttime ABPM, etc. So it's the difference between using one of the blood pressure parameter, which is daytime, which is also highly associated with prognosis. So I have no issue with this. It's just because it's easier and the probability to lose data is smaller, first. Second question about 2 or 6 months. We are facing there the problem of having either a patient off medications or severe patient on medication that you keep with high level of blood pressure. As I said, in Simplicity-HTN-3, where blood in theory, antihypertensive medication were not changed, there were 14% of patients who suffered from a major cardiovascular accident. So you cannot keep indefinitely patient without medication. And in fact, if you do it, physician or patient themselves, because they measure blood pressure, they will ask to have addition of medication. What we did is we shortened the period of 2 months to evaluate the primary endpoint, to demonstrate the efficacy, and we didn't want the patient to be without medication during 6 months. And for these ethical reasons, and also our part of the trial was done in Europe, our ethical committees wanted that the patient be back on medication after 2 months. These are the reasons why we designed the trials like this.
Yeah, thank you so much, Dr. Aziz. I think with time we're going to introduce Philip Lurtz. I would hope that all of you have an understanding that hypertension is a very complex disease. It's not even a disease, it's a syndrome. There are so many confounding elements depending on what you had for lunch, how much sleep you got, did you have a nightmare, did you remember to take your medication, did you have a fight with your wife? So there are so many things that can impact blood pressure. It's parts of the complexity, and what we've been trying to do with the rigorous trials is to reduce all of the confounding and have the cleanest data possible, which I believe we've done. Dr. Lurtz.
Thank you. So we go back a little bit to the procedure and think about how it could be done. And I would like to go through one study comparing different approaches to renal denervation. One using ultrasound, the Paradise system, exactly how you've heard already, applying 2 to 3 ablations in the main renal artery. And then 2 other approaches, not using ultrasound, but radio frequency. And there are 2 different approaches. One, where the ablations are only performed in the main renal artery, and then as a third arm, a group of patients in whom also the branch renal arteries were included into the therapy, assuming that the renal nerves are a little bit closer at the renal artery branches, and therefore maybe the procedure could be more effective. So there was a randomized trial, again with the primary endpoint of daytime ABPM systolic blood pressure. In that study, we said that we would look at the results for the primary endpoint at 3 months, and there were 3 groups as said already. And here you can see the results in blue, the group of patients with ultrasound denervation, and we saw a significantly greater blood pressure reduction in that patient group as compared to the ones who underwent radiofrequency ablation only in the main renal artery, and then the group in between, those were those patients in whom both the renal artery and the branch renal arteries were included into the therapy. So that suggests a higher efficacy of ultrasound denervation. By the way, obviously this is not a sham controlled trial, and it's never mentioned when all the sham controlled trials are summarized, but to some extent, irrespective of the approach chosen, this is again a proof that renal denervation works, because we have one approach to the procedure being significantly better than the other. And if you would say that the worst approach to the procedure couldn't be worse than a sham control, and yet ultrasound was better than this. And that was true both for systolic and diastolic. At 6 months and then also at 12 months, the effect was a little bit attenuated, small numbers, and therefore no statistical significance. But remember that after the assessment of the primary endpoint, there were some changes in drug medication and therefore some confounding, but overall a consistent finding also over time. And then I would also like to give a short summary of something which is really hot off the press and it just had been presented by Jost Dahmen's group. And these are the achieved study results, registry. And what's really important here is that the investigators, they managed to get a really very long follow-up, up to 8 years. The study protocol does not have to be discussed in too much detail here. There was a prospective and then retrospective data collection, but to make it short, the prospective efficacy cohort of 27 patients, agreed, this is not a huge cohort of patients, but as said before, there is a 8-year follow-up in those patients showing that compared to baseline, they had a almost 20 millimeter of mercury systolic blood pressure reduction on ABPM. So this is very encouraging. We ourselves have some data going up to 4 years, and also here we see quite maintained blood pressure reduction results also over time. And here I would like to stop and go right into the discussion.
Yeah, thank you so much. So you have prepared incredibly valuable data. That's head-to-head comparison of the different technologies. You showed the efficacy. Those data are really valuable. I wish we could go back to some of the items we talked about earlier when Dr. Geary was speaking, and if you could compare timing of the procedure, perhaps, pain, and interoperational variability between the different technologies and how ultrasound might be beneficial in each of those domains.
So the time of the procedure obviously depends a little bit on the duration of energy delivery, but also on the total number of ablations you have to perform. And if you can have a technology which allows you to stay in the main renal artery only with an adequate penetration depth of the energy, then you get away with less ablations and still have at least the same effect. And therefore, obviously, ultrasound was much shorter than going both into the main renal artery and into the branches. That's obvious. The same is true for contrast use and also use of radiation, obviously. Pain also correlates with the number and duration of ablations. So when you do less and a shorter time of energy delivery, then you will have less pain. And then the variability of treatment effect, that was your last question. Well, this is not necessarily that straightforward to
the variability of what the operator does, how the result is depending, is there operational variability less?
Sorry,
So with the ultrasound procedure as opposed to radiofrequency ablation, for example, when there are multiple sites, multiple ablations, is there more consistency in terms of procedural result and less variability between operators and procedures?
I would say so because the procedure is easier, right? You don't have to do too many complex maneuvers going into small branches, but stay in the main renal artery, and therefore it's just an easier procedure.
We'll take more questions. Oh, we have a question here from the audience, and then I'm...
Yeah, this is Gus Abusat, San Antonio, Texas. My background is intervention cardiologist. I want to thank everyone for the efforts made in this domain. I'll be the first one to use it, but I have 4 questions. I think these are important for me because I'm skeptical still about these are the questions. Like you mentioned about elderly patients. 1/3 of my patients are elderly, they don't like to take medicine. And there's the arterial stiffness. This is part of the spectrum. How we can measure that, I actually discuss it with our patients, and Like, they're very calcified arteries. You measure the blood pressure, you don't get really, you have to take 20, 30, like this question number one. Number two is, can we use this as monotherapy in those patients who don't like to take medicine? Like me, I don't like to take medications. And I like exercise, so I also weight loss, and then 3 biomarkers, have you used biomarkers in these studies? Have you measured like renin and stuff? Because, I have patients, they come to 100, and they show me like 100 at home, and it's very variable. Like, so, I mean, did you use biomarkers to kind of support your results? And number 4 is, if you have a patient who was resistant to the treatment, can you bring them in a 3 months, 6 months, repeat the procedure? Thank you.
Can I take the first part about atrial arterial stiffness? I agree. If you have a patient with a completely calcified aorta, then I would guess that the effect is certainly reduced or not visible. Having said that, the mere fact that you see high arterial stiffness doesn't mean that they respond well to renal denervation. We've actually proven that stiffness goes down after renal denervation because it's not just due to irreversible structural changes, but there's also a sympathetically driven component to arterial stiffness, and this is perfectly modifiable with renal denervation.
I think I might take question 2 and 3 unless Dr. Azizi, did you want to handle? No. So biomarkers, great question. We desperately want to figure out who those patients are who don't respond and who the patients are who are maximal responders so we can maximize efficiency of our resources. We have yet one common denominator for all the patients who have terrific response. The higher the blood pressure, the greater the fall in blood pressure, and that's across studies and across modalities. We would all think that if we had a measure of sympathetic tone, patients who had higher measures would have a greater fall. So along those lines, there have been 2 studies done looking at plasma renin activity and aldosterone with the hypothesis that those who had a higher renin beforehand would have a greater response, and that the response, renal denervation, would actually diminish renin activity. One study was positive, one study was negative. It turns out that renin is a hormone that's highly dependent on posture and salt, and in the world we live in, we eat a lot of salt. And the renin system is sitting down very close to 1, very, very low level, so it's really hard. We would have to do very exquisite physiologic studies to determine that. Patient question, can we treat somebody who's on no medications? Let me show a few slides, and then we're going to talk about patient selection, I think, as soon as we get to that. Multiple treatments. Anybody like to comment on second treatment? We have no human experience in our trials.
One question that arises is, it kind of is related to some of the data that Dr. Lur showed, is he's out to 8 years with just a couple of dozen patients. And the reason you might anticipate needing a second treatment is because maybe your first treatment was inadequate, but if you have procedural reproducibility, which was acknowledged earlier, on circumferential denervation, that ideally wouldn't be a reason to need a second treatment. So then the other reason is that you have re-enervation. Yep. And in other areas, peripheral nerves, there's a stereotypical rate of regrowth of nerves. And what's actually happening in the renal periadventitial nerves is a little bit up for debate from what I've read, but I think Michelle and Amy will probably have some opinions about that.
Yeah, I'll share some slides. We do have some anatomic evidence of nerve regrowth, but no evidence at all of their functionality. I'm going to talk a little bit about the patient journey so we can answer questions about who the best patients are. Renal denervation is inherently an incredibly innovative field and an innovative technique, and the creativity and the energy that we put into novel thinking started at the very beginning of the patient journey, and that was recruiting them into our studies. We used Facebook ads for enrollment in the SOLO study. That was the first study with patients off medications. Look at Facebook advertising benchmarks and the average click-through rate. That means if you see an ad, what is the likelihood that you're going to click on it on Facebook? So it's less than 1%, 0.89%. And the green bars is pets and animals, your cockatiel dancing ballet. And we've got yellow bars is food, so if you have a TikTok recipe that's going to go viral, that's how you're going to get biggest hits. Or you can be enrolling for a renal denervation protocol, because look at the number of hits. We had 5 million impressions in the campaign, and the clicks were 4 times the average engagement. So that was our first clue that patients are really interested in this procedure. And patient interest has been confirmed by multiple patient preference studies. Here's a study that we presented at AHA Hypertension in Boston 2 months ago, the patient preferred trial, and we're preparing the manuscript. This was a discrete choice experiment where 250 patients were asked to choose between multiple treatments. And that's really what shared decision-making is about. It's a choice. Would you prefer to take your medication? Would you prefer to take another medication? Or would you prefer a procedure? And it turns out that 42% of patients, sizable amount, would prefer renal denervation rather than taking another pill. And giving the same number of pills, 42% would choose intervention if it reduced cardiovascular risk. This study is not alone. We're now collecting patient preference studies around the world, and they've confirmed that many patients would choose renal denervation. They're coming up to about a third of patients in these trials. So again, these are patients asked hypothetically, what would you choose? It doesn't mean that that's what your patient is in the office is likely to choose. Somebody might say yes, definitely, and somebody might say no, I'm not interested. But I have to say it was eye-opening to me how many patients really are interested in the procedure. When I first started in this program back in 2015 and presented this to my hypertension group at Harvard, we all said, yes, I understand there's going to be a lot of interest in the TRIO trial. Patients with resistant hypertension are going to be lining up and they're going to really want more therapy, a different therapy, but not for the solo. Patients who are easily controlled on 1 or 2 meds, they'll never want to do this trial. Boy, we were so wrong. It turns out that a lot of patients with mild to moderate hypertension were quite interested. The floodgates were really open for that enrollment. We had lots of ease enrolling for that. So a surprise that we learned from patients. We also learned that patients want different things than doctors. When Dr. Schmieder at Berlin did this study, he talked to doctors and said, who would you recommend? And doctors say, we recommend our patients who are at highest cardiovascular risk and patients who have the highest blood pressure. Look at what the patients say. So in the top graph, you can see systolic blood pressures from the left to the right going from 120 all the way up to greater than 180. There's no difference. It isn't as if the patients who had severe hypertension wanted and the patients who have mild hypertension didn't. No bearing at all. The bottom set of bar graphs looks at the number of pills you're on. Is it the case that patients who are on a lot of pills want the procedure and patients who are on no pills are not interested? There's a U-shaped curve, and I think this has been borne out in our practices. The highest single mode were patients who were taking no medications at all. So whoever said they would like the procedure, you're not alone. That's the majority of patients said, I don't take any medicines, I don't want to take any medicines, I'd like the procedure. Patients who are easily controlled on 1 or 2 meds, those are the patients whom renal denervation really is not what you need, right? They're going to be well controlled with keeping their salt intake down, not overdoing alcohol. And those are the patients for whom renal denervation is not your go-to right away. And then as you're requiring more and more medications, there was an increase in the request. So I'd like to talk a little bit about shared decision-making and see when you talk to patients in your office about this procedure, you've got a patient who won't take any pills at all. What do you think? What do you think, Michelle? I'll start with you. Would you offer it to them?
Yes, I regularly offer to them.
You regularly. Do you want to pick up the mic and explain?
Yes, I will, well, I stick to the European guidelines. So really, I select the cases during my consultation.
You know what, let me share them because that
Okay.
can be a good segue for you.
Yeah.
So
Okay.
in 2018, the European guidelines said no, right? There's a big class 3 box until we get further evidence of safety and efficacy. Well, now we're here, right? We've gotten that further evidence of safety and efficacy in 2023, and maybe you can walk us through the guidelines, how you arrived at them, and the patient populations here. We have patients who are uncontrolled despite antihypertensive therapy, or if drug treatment elicits side effects and poor quality of life. That's one category of uncontrolled hypertension, and the second, patients with resistant hypertension.
That's true, and I think it's an opportunity that we already discussed, that those who are really, we have sometimes patients who are intolerant to any of the drugs we use, they have intolerance, and it's a nightmare for them to take pills, and it's a nightmare for us to prescribe a treatment because every time they come back and they have a side effect. So these persons, we offer them here a possibility to be treated. Otherwise, we were looking at them trying to reduce the dosage, to make combination, just cooking some recipe at home and present it to try to control blood pressure. The others also are those who are non-adherent to treatment. Here, and during the European guideline, we didn't put this patient, but we have patients, we share this type of patient, they don't want to take any pill. That's the reality. Each time you check, you find 0 antihypertensive medication in the urine. So whatever you try, they will have high blood pressure, and you leave them like this with a very elevated blood pressure and high risk of having a stroke, heart failure, whatever. So here, again, we have an opportunity also to lower blood pressure. And as was said before, any millimeter of mercury decrease in blood pressure has a beneficial effect.
Yeah, I couldn't agree. We need to understand at a very deep level how many patients don't take their medications. And some of them, it's very obvious. You give them a calcium channel blocker and they develop peripheral edema. And we understand that. But some of them, you give them a calcium channel blocker and they have eyelashes falling out. And we don't understand that. But there are long lists of complications like that, and we all have patients with medication intolerances, and they're real, regardless of what the reason. I think I'm going to ask Dr. Geary to talk about how the SKY position statement dovetails with the European guidelines, because this is also just released this summer.
Yes, yeah, we had a group of folks who came together to try to think about primarily what your center needed to have and what your operators need to be trained in order to have an effective renal denervation program. And traditionally in the U.S. thus far, most of these programs have been located in so-called hypertension centers of excellence. However, I think for the amount of population we have to treat, it's unrealistic, I think, for the American Heart Association to roll out 2,000 hypertension centers of excellence in the near future, considering there's only a few dozen of them now. Thus, what we have recommended is key is having those champions, a champion interventionalist. This is a full of interventional cardiologist, but it certainly could be an endovascular specialist of a different sort, a vascular surgeon or an IR as well. And then a champion in the outpatient side. And that often could be, in our place it is, a nephrologist who's really interested in hypertension. But I certainly know cardiologists and vascular medicine specialists, primary care docs who also have that interest. But having those two champions ends up being the core of what is necessary to really get your program off the ground and to manage these patients appropriately. It's important that one of the key questions that it seems to be alluded to several times is what are we going to do about these patients who don't want to take any meds? The efficacy data looks fairly clear on that. It was elegantly performed by the investigators here. However, in the US, I think a lot of that will end up coming down to regulatory and payer decisions of who you'll be able to treat at least efficiently. We certainly have seen that with other both interventional and pharmacotherapeutic interventions over the past couple of decades, that plays a major role. Nevertheless, building that system, which I think will end up being at least recommended, if not required by payers, to have the non-invasive portion of this really tight and covered is extremely important. I think for this audience, that's the main message I want you to walk out of here with. You all are going to be able to engage a renal artery, put a wire in it, and blow up a balloon 3 times. I mean, this is not rocket science. But in order to do this right, you really need to partner with somebody who's passionate about it. One of your partners, perhaps in cardiology or in nephrology or in primary care.
Or endocrinology.
Endocrinology, I'm sorry to leave them out. Apologies.
Thanks so much. Let's hear about the experience in Germany. When you're choosing patients, Philip, what goes through your mind?
I mean, this is still in an early stage of the therapy, right? So I think it makes perfect sense, and this is what we do to stick to the guidelines, to approach those patients and offer it to patients who were less successful with, let's say, conventional approaches to blood pressure control, whether this starts at 3 or 4 or 5 medications, or maybe also after 2 drugs. That's something we can debate. Early stage, we should treat those who are already on medication. But at the same time, having said that, we need to prepare ourselves, and that will change, and whether we like it or not, the patients, they have a say in that, and if we don't respect that, we lose their trust, and then we are in a situation where we have no chance to improve their medication adherence at all. So it's going to be very interesting, and I think it will be, as it's underlined already by you, it's going to be a shared decision-making, including the patients, and it is obvious that there are many who do not want to take any pills. And by the way, this is not because they forget to take the drugs, and there are some nice studies using apps, reminding applications, making sure that they will not forget the drugs. That's not the point. It's a clear-cut decision not to take the drugs.
That's exactly right. I want to draw a distinction between patients who are taking no medications and patients with resistant hypertension. Actually, I want to say that there may not be any distinction. A patient may come out and tell you, I'm not taking any of your medications, or they may not tell you. And half of patients with resistant hypertension don't have resistant hypertension. They're just not taking their medication. So you can write a prescription, a second prescription, a third prescription. Far and away, the referrals that I get for patients with resistant hypertension who are on 4 or 5 drugs, I know already what the diagnosis is. They're not taking their pills. So they may tell you I'm taking 0 meds. They may well tell you I'm taking 3 meds or 4 meds or 5 meds, but it's the same. They're not taking their medications. It's a really pretty easy diagnostic decision, and we confirm it with urine testing, and it's remarkable. It's astonishing. So I think I have 1 or 2 more slides here that I'd like to make sure we answer. Any questions in the audience? I would like to tell you all that there, in addition to the European Society of Hypertension guidelines and the SKY guidelines, I'm working on the AHA scientific statement on renal denervation. A draft is circulating among the senior authors, and by Thanksgiving, it should be out for peer review, so please take a look out for that. Panel discussion. So do we have any questions in the audience that we should attend to first? Otherwise, we've got a lot of questions that we can get to. Yeah. So, Dr. Lertz, you talked to me in the beginning of the day, and you said it might be really helpful to answer the question, how do we think this works in the first place? Let's get high level here. What is renal denervation even doing?
It's a very difficult question, but I'm still happy that you're asking it, because I think that we have to talk about it a little bit more. Normally when we do stuff, we know how exactly the mode of action, sometimes we don't, but obviously it's much more rewarding and fulfilling if we understand it a little bit better. There are different proposals of mechanisms so far. Those obviously the main mode of action is less sympathetic drive, and that has implications for peripheral resistance. That has also implications for aortic stiffness, which then in turn has consequences for the forward and backward wave, how it is transmitted, and the augmentation of blood pressure. So these are obvious modes of action. But another approach to it, and there's also already some interesting data to it, is less stressed volume, something which is really difficult to assess, but I think it matters in many diseases, but certainly also in hypertension. So to make a long story short, it's mainly less sympathetic drive and everything which is related to that, but I think we have to investigate it a little bit more and also discuss it more, because obviously we would like to know how things
we would like to
work.
Know. The more, yeah, thank you. The more we understand the mechanism, the more we can target who's going to respond, but we think that it's denervating both the afferent and the efferent branches of the sympathetic nervous system. Thank you. I think, Jay, I think it's really important for most of the cardiologists here, interventional cardiologists here, to learn a little bit more from your system. So you're an interventional cardiologist. The patients with high blood pressure who are not controlled, they're not living in your clinic. They're not living in your clinic either. If they're very difficult to control, they're coming to see Michelle or me, but most of them are in primary care practices. That's where the vast majority of patients that are going to end up benefiting from the procedure, this is where they're getting their care taken. So how do we reach these patients, identify the patients, and end up getting them to this therapy that could help them so much? So I don't know who wants to begin with that.
There's the present and then there's the future. The present is it's happening through typical referral pathways. But the issue with that is that that method has been failing from a population health standpoint. And I think that I've heard other talks from Naomi that clarify that significantly. But the future, I think, goes into utilizing our EMRs in a more effective way to ascertain which patients are controlled and how to shunt those patients into appropriate control. I do think we probably have to give final comments from me here.
This time flew by. I really want to thank RECOR for sponsoring this very, very important symposium. Thank you all for joining us. Thank our terrific panelists, Dr. Courtney, who had to run, Dr. Azizi, Dr. Lertz, and Dr. Geary. And here's to raised awareness, spotlight on hypertension, and treatments that are effective with renal denervation. Thank you.